morning, everyone. Give you a minute to take your seats. Thank you so much for coming out on this uncharacteristically of Houston cold and dreary morning. But I think you're going to find yourself well rewarded by the speakers we have today. So welcome to those who have never been here before to one of our Baker Institute healthcare conferences, and thank you again. You know, I see a lot of familiar faces, and so that's great to see as well. Thanks also to the Health Policy Forum members who make this this event possible. It's not cheap to get these organized, and we're very appreciative of that support from the Health Policy Forum as well. So let's give you a little bit of an introduction of why today's theme about cost control. Now, the Baker Institute, as you know, is all about providing you objective information on health policy to allow you to make decisions about what you'd prefer from our leaders at the local, state, and national level. We are not advocates. We are never going to tell you who to vote for. Now, if some of you were here for the summer luncheon talk that I gave, and it went through the various different Democratic platforms on healthcare, and I think if you'll remember, we did discuss Medicare for All at that get-together, so it's not going to be talked about here. I hope you recall that there were a number of numbers on there that indicate that particular proposal is just not financially feasible for our country. If you want to review, look at the Policy Matters podcast that the Baker Institute puts out, because I just did a discussion with Joe Barnes about that was posted yesterday. Now, I know there are still many idealists who still want to have health care insurance for everybody in this country. I'm sympathetic to that belief. I just want to point out to you, though, even if we have a Democratic president, we'll probably have a Democratic Congress. Maybe we'll get a Democratic Senate. Not likely, but maybe. Even after all that, we're talking about passing a very aggressive, if Medicare for All, it's a very aggressive platform. We have a completely different Supreme Court in power right now. So I'm sure there are plenty of lawyers that would challenge anything like what is in Medicare for All. The wealth tax, they will find out a reason for that to be unconstitutional. They will find the elimination of employer-sponsored health insurance. They'll find an argument for that to be infeasible as well as the idea of getting rid of private insurance, okay? So what I'm saying in terms of practicality is that is not a direction that we're gonna be able to go in. If we spend a lot of time dwelling on it, we are wasting time, because as you and I know, there are tens of millions of Americans who are having problems paying for their health care now. They're both uninsured and insured who are facing difficult problems, and that's why we need to focus on the topics that we're looking at today. So we have 4 expert speakers. Their official bios are in the program. I'm delighted that they were able to come today. Some of the topics they will talk about are familiar, and some are completely unfamiliar, and I think it's good to see just how complicated our system is. There's no one easy fix, but they're going to give you a lot of very interesting ideas to look at. So the format of the program is each speaker speaks for 40 minutes, generally uninterrupted, okay? So save your questions, and then we reserve that 20 minutes of time for you to ask your questions. And I know this is, I'm looking forward to a very interesting exchange, because I know a lot of you have terrific questions to ask, and that's one of the best parts about this conference. There will be people with microphones who will come to you, raise your hand, and they'll bring you a microphone to ask your question, because this is all being recorded, and we want people watching the videos to be able to hear the questions. Just in terms of logistics, ladies' room on this side, men's room on that side. Okay, so with that, I'm going to get started with our first speaker of the day. We still have a speaker who hasn't come here yet. He's coming from the West Coast, so he's a little bit jet lagged, but he'll make it here in time for his talk, I'm sure. We are starting with another West Coaster, Dr. Jonathan Kolstad, who's a professor at University of California, Berkeley, and I will not read out his bio to you because I find that kind of boring. But let me tell you a little bit about Dr. Kolstad's research. He's published a number of excellent papers. One of the things I find remarkable about him, he collaborated with others to look at the introduction of Massachusetts healthcare reform, Romney Care, well before Obamacare came out. And so by doing that analysis, he was able to give health economists a prediction and assessment of how would Obamacare play out if run effectively and maintained properly. And so, for example, one of the papers he did showed that Romney Care actually did lower health insurance premiums in Massachusetts overall because they had a very tight individual mandate that was part of it, and actually put dollar values on the improvement in consumer welfare. So this is a policy that works if you're able to introduce it effectively. And so another paper he's written out a completely different topic, looking at privately insured deductibles and what are the effects of deductibles. And you would think there are two different ways that workers could respond when they see a deductible in their policy. They could either use fewer services, or they could go and shop around and be more aggressive about the types of services that they would choose. And surprisingly enough, they chose not to shop. They just used fewer services. Okay, and then that has important implications for how healthcare plays out. But Dr. Kolstad has a different topic today: innovations in health insurance that can improve U.S. healthcare efficiency. John.
Thank you very much, Vivian. Thanks for having me. I'm also a jet-lagged West Coaster, but I did show up. Well, in body. We'll see if in mind shortly here. But thank you for coming out. And I'm excited this is a very different talk than I typically give. Usually, since we're in Texas, I guess, we drill a deep well in terms of one topic, and we focus on that, answering a particular question. Today, I'm going to try to kind of come up a little bit and to some degree anyway, we'll see the forest for the trees in terms of thinking about really what private insurance does and doesn't do in the US and how it might affect really healthcare efficiency overall. And I should say at the outset, and I'll talk a little bit about it here, is that the title, as I was putting this together, when we say, well, you're coming in 2 months, give me a title. And these journals actually sort of come up with a title which is sufficiently general. I think the title may belay slightly more optimism than I'm going to come up with at the end, but we'll see. So what I'm going to try to do is I want to start by just putting healthcare cost in the US in a somewhat broader context. Part of this whole talk is going to be about where healthcare costs fits into bigger societal issues of income inequality, bigger societal issues of the overall budget, and then that's going to lead us, I think, pretty quickly into the role of insurance at that high level. Obviously, we're going to have some more fantastic talks today that are going to begin to drill in much deeper to particular ways payments are structured and things like that. But I'm going to try to here ask some broader questions. So I'm going to start with thinking about health income and insurance. And then really get into insurance coverage, incentives, and innovation to improve efficiency. So how do these things come together in our current system? And unsurprisingly, a lot of that is driven by some form of kind of market forces, and ask the question kind of what can markets do in healthcare and health insurance? And you can see parenthetically where a lot of this talk is going to end up, which is the simple economics and simple economic predictions of the neoclassical model don't seem to be borne out here, and that has important implications for where we think limitations for the kind of conventional regulatory and conventional market forces that we might hope would be effective, the limitations are going to have here. And then, that'll be the less, more dreary part, consistent with the day, and hopefully end with at least some optimism for approaches. One specific one, which is a very specific example of how technology might help us make these markets function a little bit better, and then coming out a bit to talk about, the fact that really at the end of the day, regulation and policy is going to be central. And that can come in the form of full Medicare for all. It can come in the form of a tightly regulated market. But there's the one punchline is really going to be that the market alone has not and doesn't seem likely to deliver the kinds of innovations we need for efficient cost reduction. And I'll tell you what I mean by efficient shortly. So the key ideas, in case you go back to sleep shortly, is the first one is that the U.S. healthcare cost is really linked to income and social structure, not simply the healthcare system. And I kind of want to revisit that point. I think, myself, I'm very much guilty of this, as you get in the weeds of health policy and thinking, well, if we just had ACOs or we just had this form of payment structure, then everyone would be healthy, wealthy, and wise. And ultimately, I want to sort of try to show at least a little bit of data that we need to remember that anything we do about healthcare cost within the context of the healthcare system needs to be viewed in the broader lens of inequality and social structure. And a part of that is also, I want to visit this particularly in the context of the policy discussion, the role that healthcare cost simply plays in our tax structure. If we start thinking that, in fact, employer-based insurance, even though we don't formally call it a tax, is effectively a tax, right? That people are paying that. And then thinking about insurance and efficiency costs are inextricably linked. I've sort of mentioned that, but really, the U.S. is unique in its reliance on private insurance, and therefore, if we're going to get efficiency and innovation, it's going to have to come from private insurers, and that's a central issue and central question. And then the third kind of key idea is that we don't have a lot of evidence that markets and insurer competition today really are delivering the innovation that we might want to efficiently reduce cost. And then lastly, as I said, I think there's a very important role for market design and private sector tools. I'm coming from Silicon Valley, so I have to put a plug in for the excitement and probably overhyped, but AI, digital health, those things are potentially very important and potentially very impactful. One theme I'm going to come up to again and again is consumers are inefficient and unable to make these complex decisions. That's a natural role for decision aids, tools, technologies that have not really been deployed, but those are only going to be as successful as the regulatory structure into which they're dropped. And Vivian mentioned some of my earlier work in Massachusetts, but there you see exactly that kind of theme, which is you can lower premiums, you can have efficient reductions in adverse selection, but it requires, and you can have the market function, but it requires that regulatory framework. Okay, so just to remind everyone what we're talking about. Does this have a laser pointer? Oh wow, that's not a laser pointer, that's a mouse. Oh well, I'll point. So the U.S. is unique in really two dimensions: the level of spending. So for those of you who don't have your opera glasses, per capita GDP is on the x-axis here, and that's per capita health spending. And you can see most other countries are on a nice line. The U.S. is an outlier in levels, but it's also an outlier in terms of growth rates. So if we go back to 1960, when the U.S. had about a gap relative to other high-income countries of about 1.3 percentage points of GDP, our relatively higher growth rate has left us, as of, 10 years ago now, almost 10 years ago, a gap of about 7 percentage points of GDP, total GDP, in terms of additional healthcare spending. So these are big numbers. And if you ask, why is the US so distinct? I think there's three very salient factors, at least as it relates to what we're talking about today. The first, as I mentioned, is the reliance on private insurance to determine outcomes. Now, the US is not unique in private insurance. In fact, Switzerland, the Netherlands, Germany to some extent, all have completely private insurance. The distinction is those insurance plans are tightly regulated in what they can offer. So you get competition over domains that are fairly limited. The US has had effectively unfettered entry and lots of different types of insurers. And that's going to be a theme I want to come back to again and again today, which is that would be great if we got a lot of innovation. The reason you want free entry and competition is you get lots of innovative new ideas. The question is, are we going to get that here? And if, just to think about it, 55% of US spending is going through private plans with little restriction on benefit design. The other unique feature of the US is the large uninsured population and also the large, I'll call it underinsured. We can talk about precisely what that means, but increasingly limited health benefits. And if you think about that, it's now very varied. Increasingly employer-sponsored insurance covers less. There's more bronze plans on exchanges, and you also have extremely different implementations of the ACA that lead different states to have very different levels of uninsurance, but there remains a lot of uninsurance. And then the third one is the remarkably high levels of income inequality in the US that I want to talk a little bit about, as it relates to healthcare outcomes and the role of insurance. And 2 and 3 certainly go together, that many of the lower income populations have less insurance. The other sort of framing piece I wanted to bring up is some recent work by two of my colleagues, Emmanuel Saez and Gabriel Zuckman, thinking about healthcare costs in the context of the overall income distribution. And I thought this was relevant since we're really talking about why and how might we lower healthcare spending. It's something that I think has not been brought up enough, which is if you start including the amount we pay in employer-sponsored insurance towards premiums, the US starts to look like among the most taxed countries in the world, certainly in Europe. We sort of ignore that, but perhaps even more concerning is that effectively insurance is something that looks like a poll tax, which is to say the average cost of insurance is the same across all employees. And because all employees are offered the same benefit, it's effectively a regressive tax that the low-wage workers also have to be basically working with that $13,000 average insurance cost the same way as someone who's higher wage. And here you see, and I'll point to it since I can't use my laser pointer. This is the income the income distribution in the U.S. in 2018, and what you can see is just how regressive the overall system becomes if you add in the cost of health insurance. It's a pretty remarkable fact, and I think underscores one of the challenges in linking insurance to employment, and also the fact that healthcare cost is so high. Okay. All right. So with that, let me spend a brief moment thinking about what I mean when I mean efficiency relative to cost. And this is reproduced from some work by David Cutler. But generally, what we see here is the resources going along. So as we spend more, we're getting diminishing marginal returns, so we get more health, but at a lower rate. And what we want to think about are 2 forms of inefficiency that might exist in the US. The horizontal one here is what we call allocative inefficiency. That's that we're doing more stuff than we'd like. And that's the general idea that oh, wow, cool. It may or may not show up on a digital screen. It's being absorbed. All right. That basically we're using more resources for healthcare than we would like. But the other form of inefficiency, which is somewhat less talked about, is productive inefficiency. That vertical line, that even at the level of resources we're using today, we could be more effective, getting more health for our buck. Both of those forms of inefficiency are what we would want to ameliorate, okay? And the important thing to take away here is when I talk about innovation for efficiency, I don't mean reducing cost. In fact, in some domains, we might want to increase cost, right? What I mean when I talk about innovations for efficiency is that you're cutting back at the margin, that we're getting rid of things that are ineffective and increasing things that are effective. And that's going to be an important point, I think, broadly, but it's also going to be important when I get to the empirical evidence for whether or not the kinds of innovation we see is, quote unquote, efficient, okay? And I think that also is in somewhat contrast to a lot of the policy debate, which sometimes just takes healthcare cost as, we know it's too high, let's just cut it back, that's good policy, right? Which is a blunt instrument at best. All right. So as we get into this, and I want to sort of build up to where insurance coverage comes from and how it might be effective, I did want to revisit just this broader role of income and health in the US and thereby on insurance. This is data from the Medical Expenditure Panel Survey. Here you can see the percent of the federal poverty line. I've broken it into buckets that correspond to the subsidy levels for the ACA exchanges. And what you can see is this remarkable gradient in the share of the population saying their health status is poor. That if you're in the lower income distribution, there are far worse health. We could do this with spending, we could do this with specific diseases. You would get a very, very similar picture. And the question is kind of, where does this come from? And in fact, is this something about our healthcare system? Oops, I'm now going forward. All right. Is this a uniquely American issue? And I think there's a really nice set of work that suggests that, in fact, there is something unique and challenging about this. And I'm going to talk about this in the context of health, but this is very correlated with the efficient use of the system as well. This is some work by Alice Chen, Emily Oster, and Heidi Williams looking at infant mortality over the first year of life. And the interesting thing here is that actually the U.S. looks, many of you may be familiar with this, the U.S. does very, very poorly on this dimension relative to other industrialized countries, particularly in Europe. And the question is, where does that come from? And in fact, what you can see here is if we look early on in life, there's very little gap. So Finland is amongst I think it's the number 2 or life expectancy in the world, very high. Austria is sort of the middle of the pack in Europe. The US is actually relatively close to them, even out through the first month of life. It's in that first year, by the way, when lots of insurance falls off, lots of the sort of outside of hospital stuff starts happening, that's where the gap seems to come from. And I want to bring that up because we're going to focus, in effect, we're focusing a lot of our time, particularly when we get into hospital payments, et cetera, on day 1 and week 1, right? Are we over-incentivizing C-sections? Are we doing all these other kinds of things? But that big gap is coming later. And if you then dive in on it, it's pretty striking. So if we break this down into what they call advantaged and disadvantaged groups, this is basically an index of income and education. It's quite striking that being advantaged in the US has a complexion of these European countries, that we're right on top of them. Infant mortality is almost identical. On the disadvantaged side, by 1 year, we're almost double the rate of 1-year mortality, right? And that's entirely, again, coming not in the context of high-intensity healthcare when babies are born. It's coming far after. And, and this paper is fantastic if you're interested. There's lots of other ways we could cut this. It's striking geographically within the US. It's striking with respect to education. But I think it's important context for thinking about where we might impact both health and healthcare cost. And this is also, I think, is going to be one reason I want to focus on insurance. That insurance is actually something that, in principle, provides access to lots of services even after you've left the hospital. Obviously, it's relevant to the hospital, too. And in fact, that's one motivator for why the ACA was so focused on expanding coverage. And if I just want to kind of revisit, we have the current incarnation, but revisit the original plan. First off, you had basically Medicaid expansions, which meant everyone up to 133% of poverty was going to have coverage there. Then you were supposed to have state-level exchanges, which would be effectively run, able to manage and target at the specific state level the best plans within that geography, and then basically building on a backbone of existing employer-sponsored insurance. So this is the idea. And in fact, I would argue in the first, it was always uncertain, but in the first year or two, it was much more certain. And in a world with guaranteed issue and community rating, which basically means that insurers can no longer compete along the dimension of let's avoid sick people. They now have to compete along the dimension of how do we manage disease efficiently. You saw an entirely different complexion. I know there's people here from the insurance industry. As someone who sits in those C-suites and talks to people on occasion anyway, the complexion of the conversation was totally different, right? No offense to, I'm sure there are some actuaries in the room, so cover your ears. But the actuaries were somewhat out of the C-suite, and the strategists were in. They were saying, how do we manage diabetes, not how do we avoid diabetics? That was a fundamental difference. And I want to sort of think about that because we're going to come back to this, that's the kind of innovation that's going to come back down that cost curve, right? How do we get more diabetes maintenance drugs to the right people and less downstream amputations that are very expensive? And an argument for why that happened was that you had this regulatory environment where coverage was going to be near universal. It was difficult to turn people down, and in fact, you had to manage the population that you received. And in fact, because of risk adjustment, and we have an expert on risk adjustment over here, and Mike, you were not penalized too much for having those sick populations. So basically, doing better than average in treating diabetics was profitable. So that's maybe a rosier picture, but what actually happened ended up being quite different. You saw a number of states turn down Medicaid. They end up with federal exchanges, Obamacare exchanges, which are, to a first approximation, parachuted in from above. So they're much, I think there's good effort, but they're less well managed at the state level in terms of managing the marketplace. There's much less effort or ability to do risk adjustment and manage the kinds of policies that would make markets effective. And on the employer-sponsored side, instead of keeping existing plans, you've just seen the continued march of high deductible health plans and the moniker of consumerism. So that's a very, very different complexion. And I'm going to argue that that's one reason you've had a very different narrative around what has actually happened, which frankly feeds directly into the fact that healthcare is back on the presidential discussion only 10 years after we first tried to, we had the biggest change that actually made quite a bit of progress. Why all of a sudden are we talking about it again? In part, it's because we ended up with a complexion like this, not like the original plan. And so there is this narrative of low satisfaction, high premium growth, and that people really hate this mandate. And certainly there's truth to that. But I think the evidence is a little bit distinct from that you have seen incredible coverage increases. So the US, in many states, is very low levels of uninsurance, the complexion that's completely different from what you saw in 2013. Medicaid expansion turns out to be central to that. If you start digging in, it has huge implications both for coverage rates, but also for the function of the marketplaces. So adverse selection on the marketplaces is much worse when you don't have Medicaid, because basically the higher income poor who can get subsidies end up on the exchange, but they only do so if they're sick. That leads to unraveling. And I think you have this just big bifurcation, and I can say this, people can throw things at me if they want to, but I said beforehand, don't watch the whole country, watch Texas and California for the ACA, because those two states, we had almost exactly the same levels of uninsurance, huge populations, huge economies. Texas still has about the same rate of uninsurance as you had before the ACA. California has cut it in half, has a functioning marketplace and stable premiums. And that's arguably because of the way the marketplace was managed, and I would argue that you've had a lot more innovation on insurance too. So I'll duck now. I think that's one big piece. The other piece is that you have a lot of enrollees that are dissatisfied with their health insurance, and that's something that I want to get into now, which is innovation that ends up looking like higher deductibles when people can't effectively choose is a big problem in all of these domains. That if you can't get effective choice, not only do you not get the kind of competition that you want, you don't have satisfaction among people who are insured. And you've heard it a lot. I did what I was told to do by, I signed up for insurance and I'm still bankrupt because I got a bronze plan with a $6,000 deductible and I have $30,000 in income, right? That choice is also a central piece that's not really been discussed, and I want to come back to that because I'm going to think about that theme a lot today. Okay, so here's a not exhaustive, but hopefully informative way I'm going to try to go through the theory, the implementation, the practice, and then maybe some solutions related to getting more efficient delivery of healthcare and cost reduction. And starting on the left-hand side, and partly this is going to be, if I had my neoclassical trained economist hat on, it would be this left-hand column, right? What do you do to efficiently reduce healthcare cost? First, you get the incentives right. What does that look like in practice? It says, well, we have a lot of excessive use of low-value services because people don't pay for it. If they have to pay for it, they have skin in the game, right? Everyone hears that all the time from every HR consultant, et cetera. They will efficiently use healthcare. That looks like raising deductibles, increasing cost sharing. Second thing, market-based solutions, right? We want competition to provide variety and reward effective, efficient, value-based care. What does that look like? That looks like an exchange-based model. We rely on competition, Obamacare exchanges, Medicare Advantage, Part D, all of these are really market-based approaches to expanding coverage. Personalization, right? People are different. People want different things. What does that look like? We really don't want to restrict entry too much. We don't want to tell insurers what to do. We want to say, you come in, you get market share. That's good for consumers. And we don't want to limit kind of the products you would design. The fourth one here, and this might not be in the standard theory, but if you think of information frictions, that people aren't always fantastic at decisions, well, what do? I give them some information, right? You're an adult. Go figure this out, but I'm going to tell you what you need to know. It's going to be a very comprehensive statement of benefits, statement of what you're getting. And then the last one is that I want, and this is sort of related to the personalization market-based solutions, I want private sector innovation. I think innovation is driven by companies trying to get rewards, and so you'd facilitate entry by private plans. We've seen that in Medicaid. We've seen that, again, in these exchange-based solutions. So that's sort of where we've been in terms of asking insurers to innovate to efficiently reduce spending. And let's try to look at the evidence on what's actually happened. So the first thing I want to consider is consumerism. And it's really been a kind of remarkable shift, and I'm sure many of you are on some flavor of higher deductible, so this will ring true. But on the left-hand side, you see basically the growth of these different components of spending. The orange line is premiums, so premiums are going up. But the biggest shift over the last 10 years has been this growth in the deductibles of employer-sponsored health insurance. So we have this huge shift towards consumerism. On the right-hand side, I guess looker's right, you see also the rates at which in 2019 people are enrolled in bronze plans on exchanges. So we're also using, again, the same principle on the exchanges, which is if people have higher deductibles, they're going to be more efficient and effective at shopping, getting rid of lower value services. Okay? So this all seems good. In theory, this is actually a efficient form of innovation. Insurance here would be delivering lower cost, higher value. And Vivian, I think, spoke a little bit about this paper. We've actually studied this in some depth. And what we did was we studied a very, very large firm, frankly, very unrepresentative. This was a high income, high education, precisely the place where you think people have the right tools and could effectively respond. And so what we see, if you look at the lower line here, that's inflation adjusted. In year T0, we're not allowed to say the year to maintain some anonymity. Before that, they basically had complete coverage. And in year T0, they moved to the high deductible health plan. And you see this quite substantial drop in average spending. If we do a bunch of fancy footwork, that sounds a bit suspicious, but basically just estimating it directly, you see about a 15% reduction in overall spending. So that's fantastic, right? If we stopped there, we'd say, wow, under standard theory, when people give up the lowest value first, this is basically lowering cost and we're getting rid of low value services. And in fact, that's where most research had stopped to that point. Precisely the research that was saying basically these high deductible plans were going to be efficient, that you say, under standard theory, this is great, we've lowered spending efficiently. The problem is when you start looking under the hood, the complexion begins to change. This plots the effect across 4 quartiles of health risk. So the ACG score is just a fancy algorithm to predict future spending, but it's basically a measure of acuity. And what you see is that, in fact, the drop is largest amongst the sickest people. So that's already a little bit concerning for 2 major reasons. The first is one reason these deductibles are supposed to be efficient is that if you're really sick, right, if you're going to MD Anderson because you have cancer, you're going to spend all the way through the deductible, so you're less responsive to prices. And in fact, we like that because we think, where is more spending going to be effective? Or where do you want to protect people from risk? When they're sick. But we're not finding that here. We're finding large drops amongst the sickest people, but really across the entire health spectrum. So that's concerning. And then what we do is we break down how people responded to these increased incentives for consumerism into 4 buckets. The first is just inflation, so you can ignore that first bar. So the total drop, as I said, was about 15%. the entirety of the effect here is coming in that green bar, which is what we call quantity change. What is quantity change? It's simply not going to the doctor. It's extensive margin reductions in consumption, which is not a good sign for efficiency, right? If you're not talking to your doctor, how are you cutting back on the lowest value services at the margin? And in fact, and I think this is one area that this paper's been most known for, is that price shopping effect, that we find no increase in price shopping. And in fact, if anything, we find that people receiving the same service, on average, went to higher cost doctors afterwards. And I should add, since it will probably come up in question, this company was completely unrepresentative. They had the best tool for price shopping. The data were populated. They could look up doctor prices. They had all the information needed. And we still don't find any effect there. Next, we can break down where these cuts came from. And we start by looking at what we would classify medically as low-value services. And in fact, we do find very large reductions in this. So this is, I think, good news with respect to kind of efficient reduction in care, that things like imaging, CT for sinuses, antibiotics for infections do drop quite substantially. So we see some of the good effects we would want. So we're cutting back on those low-value resources, going back to that curve. The concern is when we look at high-value services, we find a very similar picture. If you look here, just to what are these? Preventive care with prior diagnosis. And again, I apologize, it's pretty small, particularly in the back, but I'll kind of read it out here. That means you have had a prior diagnosis that makes a preventive visit particularly valuable. So if you've had an abnormal mammogram, you should receive another mammogram shortly. That's the kind of example here. We see a 10% reduction in that's incredibly striking, at least to me. Preventive care for diabetics is dropping, mental health use, physical therapy for people who've had surgeries. And then on the drug side, I think is incredibly striking that diabetic drugs for people with diabetes, statins dropped 47%, antidepressants dropped 48%. So this suggests that, in fact, consumerism here is a very blunt instrument. It's not giving us the kind of innovation that we might hope for, which is we cut back on this stuff that's medically not as valuable. And in fact, if anything, we'd expect more use of particularly the drugs, right? These are very effective. And it's not generating those marginal trade-offs. I told you this can be a little bit glum about what we can do. But the second paper I want to bring up with respect to these questions of insurer innovation is a different setting entirely, but starts to get at similar questions and in a similar manner. So here we're looking at the population of the state of Utah. And one reason we can do this, which is going to sort of foreshadow one of the important roles for policymakers in states, is that Utah has an all-payer claims database, a comprehensive set of data that allow us to follow individuals over time. And in fact, in this case, we know which employer where they worked. And so what we can do is replicate that first study, and that was in one firm. We can do this for 700 firms, right? What we take is every firm that only offered one plan in year T, and they switched everyone to another plan in year T plus one. And since we have lots of different insurers, we can actually back out the causal effect of being in a particular type of private insurance on spending, on utilization. And that's going to give what I think is a broader picture of what does private insurance do? We actually don't have a great estimate for that. And another unique feature of Utah is that, in fact, it's a very competitive market with lots and lots of different types of plans in it. So you can see the effect of each of the different carriers there. There's lots of national publicly traded for-profits. You've got Cigna, Humana, United. Select is the vertically integrated, not fully vertically integrated, but it's Intermountain's plan. Regents is the Blue Cross, and then you have the Public Employees Plan. And if you look at that, you see some variation, and again, I'm going a little bit quickly, but there's lots more to do here. But you see relatively little variation. The only one that seems to do something quite different is United. In fact, United seems to spend dramatically less. The other plans don't have that much difference at all. We can then break down where this difference comes from. And what we find, we break it into utilization versus prices. So one hope and one important rationale for having competing private plans is they can efficiently negotiate prices and come up with networks that really might give people higher value care for lower prices. We don't find that in Utah. In fact, the entire difference, or most of the difference, is coming from just lower utilization. And you can see that really strikingly with United, that United's prices are pretty much within the pack. It's just you use a lot less care. And the other plans, again, any difference really comes out of utilization. So this is not exactly the kind of, at least my a priori model for kind of how competition was going to be effective or efficiently reduce cost. And it gets a little bit worse that if you then look at high and low value care, and I'm just showing you one example here, but this big reduction in United and in others, what you see is that in fact, that's coming from, for example, lower rates of preventive visits. And we can do this for lots of different things. You see lower statin use, you see almost precisely the same result we found in high deductible plans, that yes, competing insurers, there are some that do spend a lot less. Those that spend a lot less cut back in roughly equal measure on high and low value care. So it's not that we're finding that really innovative insurers that spend less, for example, spend a lot less on imaging, but not a lot less on diabetes maintenance drugs or statins. So here again, we don't find good evidence that in fact, even in a very competitive market with lots of different types of entrants, that insurers are doing the kind of marginal trade-offs that we might hope for in the model. So with that, I'm gonna be a little bit quick since I've got ground to cover and I've been told, and I'm excited to hear all of your questions. But I want to spend a little bit of time on one important limitation for competition in this market, which is, can consumers effectively give market signals that are going to reward high value care? So one, we're okay with unfettered competition. The degree to which it's unfettered is an open question, but certainly there's at least two companies making phones, Google and Apple, but we're okay with people having a preference between their Android and their iPhones, and we think people have relatively good understanding of that. A concern, however, in insurance is how effective are consumers? And if in fact they're not very effective, maybe that's an important rationale for why either employer-sponsored or market-based insurance solutions, we're not getting the kind of competition we would want. Really, its exchanges are going to rely on this active, well-informed consumers to discipline the market. And this really runs counter to a lot of research, including some of my own, which is that people are very, very ineffective at making good choices in insurance markets. That's true in Medicare, that's true in employer-sponsored insurance, even with only 2 plans, and that's true on Obamacare exchanges. And the implication of that is that bad plan choices are going to actually undermine the financial value of insurance. They're going to increase cost. They're going to lower access to high-value care and medication. So for example, if people with chronic diseases can't figure out when their medications are on formulary, you can do all the cute glowing bottle caps later you want. If it's not covered, they're not going to take their medications. And lastly, and I think this is important, it also generates a lot of dissatisfaction with the policy. I think, we don't have great evidence on this, but there's certainly a concern that some of the pushback with the ACA exchanges was simply the fact that people couldn't get in the right plans, ergo it seemed like it was expensive and low value. And I think this is going to relate back to why and how we might want to rely on these kinds of choice-based policies. And I want to spend a moment just presenting, it's a little bit different evidence, but why these choice-based policies might be problematic. And I think this is really important for how insurance markets works. It's also more generally important for our focus as kind of policy wonks in saying, well, markets deliver good stuff and we want to give people more choice instinctively, right? And that's been manifest certainly for the last 30 years in a lot of policy. We have really good data from the Netherlands, and I'll tell you why we're using the Netherlands shortly, but basically there they offer a menu of 5 premium deductible combinations to go in combination with their private insurance market. And the interesting thing there is that they're very tight, they're in very tight bands. There's really only 2 options. You should do the high deductible, low premium, or the low deductible, high premium if you're sick. It's not a complicated choice, yet people are faced with 5. And then we can ask, how well do people make that choice? We find that on average, people only make the, quote, right choice about 30% of the time at the high end, if they're very well educated. But perhaps more interestingly is that there's an incredibly strong gradient with respect to income and education. And you can see that here. Basically, on the x-axis is the probability that you're going to be healthy. And as it goes to 1, like as you're certainly healthy, 100% of people should choose the low deductible. And what you see is that going across, that fanning out is by education. So that people with less than high school, really very few of them are even making the right choice. Up to the top, certainly people are doing a lot better, not only making the right choice about 25% of the time, but because it's the Netherlands, we also have really rich data, so we can actually look at exactly what degree people had. And if we had more time, I'd ask you to guess which degree does best. But so in good news, a probabilistic decision is better made by statisticians. So statisticians actually do the best. Doctors do very well as well. They're not, I think they're not in here. Yeah, so I know there's many doctors in the room. But if you look at the bottom, protection of persons, that's security guards. Security guards, so basically people in low income, low education jobs, we look at this by urban and rural. Rural make much worse choices. I think this is in a broader context, just to say, not only are these kinds of choice-based policies maybe inefficient on average at sending the right signals, they may exasperate some of the gradients with respect to income and education that we're seeing manifest across the world in terms of blowback on policy. It's not surprising, right? If someone said, hey, I just delivered all these really good benefits to you, why are you mad at me? Why are you protesting in Paris? Well, it turns out they weren't very effective at figuring out that it was good for them. And so you might say, well, okay, all right, perfect. But in the US, we have these people, there may be some in the room, we have insurance brokers, they're supposed to help people, maybe they'll send the right signals, okay? And we can actually look at this, and we rely on experts in a lot of markets, but we can look at this in the context of actually, this is a Medicare exchange. This is Aon Hewitt's Medicare exchange, so it's arguably the best place you're going to find this. It's a high-end exchange with no commissions, so it's really, they're supposed to get people in the right plan for large employers, for example, AT&T. And the nice thing is that when you call, you're randomized, so we can actually figure out who was doing a good job. On the left-hand side, this is the spread in the cost error, so how much who you get on the phone randomly matters for you. It's quite a big spread. This is for relatively low-income retirees, I mean fixed income as a retired. The average range from the 25th to the 75th percentile is $800. So it's a huge difference across brokers. If we separate them out, you can see that, and that's in the quintile of quality, so 1 being the best, you can see the mean choice error going way up. So if I happen to get one of the best brokers, they still aren't great. I lose $875 relative to the best choice. But if I get someone at the bottom, right, if I get, Jonathan Kolstad, the broker, I'm losing more than twice that much, right? So they're not very effective. And then if you look at the amount of time they're spending, so the call time or the years of experience, they're almost identical. So these are precisely the people who you might say, look, they're spending an hour with these people. They've been doing it for 4 years. Shouldn't they be effective at overcoming these information frictions? And we really are not finding that. So the kinds of mechanisms that traditionally have tried to facilitate competition are not showing up. So with that, let me sort of try to summarize in this context, which is you have theory, implementation. It looks like in practice, getting the incentives right actually led to reducing spending on low and high value services. People are not very effective at responding in the ways that theory predicted. Market-based solutions, poor plan choice, low levels of coverage, so basically people would respond to premium and underinsure, personalization, and this has only gone up since there's been less restriction on entry. You have numerous complex plan offerings that covered by tier and brand. People are just more and more confused, and this facilitates selection. Information frictions. If you look at a lot of these websites, there's excessive detail and or better user experience, which usually just looks like a cute website, but not really addressing the underlying computational complexity of figuring out who's high and low value care, what plan should I buy, and private sector innovation. We find that variation in cost, but it looks like it's coming in ways that are very blunt instruments. You can be in a low-cost insurer, but it's not high value. Okay, so what can we do? I want to be slightly optimistic here. First, I want to show you one specific example on this insurance choice domain. And I think this gets a little bit to, if we had more effective decisions, maybe higher value insurers could be rewarded. And we've looked at that in the context of, again, this Aon Hewitt exchange. And this is a tool that I helped build. We supplied brokers with a score of how a plan score that is personalized and predictive. So basically you have a bunch of machine learning algorithms in the background saying what plan is best for you, given your acuity, given your risk preferences, and given your network demand. And what we find is that, in fact, this is a complement to broker skill, that people make much better decisions. Here, I'll show you. This is the distribution of choice here, the cumulative density. You can see in 2015, that's that spread. Basically, getting a low-skilled broker is really bad for you in 2015. After the AI is implemented, everyone moves up. The average savings was about $300 per enrollee, which may not seem huge, but that's 7% of the average enrollee's Medicare spending, or that'd be $6 billion annually just in Medicare Advantage alone if people were making more effective choices. So I think that's an important component, but it's not enough. But I think what I'm trying to get at here a little bit is that these kinds of tools that can help people do this complicated math associated with insurance better, not only could they be more effective at facilitating market function, they also could be powerful for regulators or market designers. And at minimum, that's going to be a dimension we're going to need if we're going to make progress in getting competition to generate high-value plans that are going to cut back effectively at the margin. And let me just wrap it up by trying to put this in limited but maybe useful framework. So if we want to say kind of where we're getting the incentives right, so what are some solutions, both from, I'll call it technology or market solutions and policy solutions. So the first on getting the incentive right, I would argue that simpler contracts and particularly tools for doctors and patients are going to be important. So if you look at why Kaiser Permanente is so effective, one major reason is that doctors have a comprehensive electronic medical record that allows them to work across teams, respond to incentives, and meet their patients in lots and lots of different domains. That's certainly, and more generally, I think efficient innovation in insurance is more likely to reward the people who have been to medical school or incentivize the people who have been to medical school, and less likely to be coming from just giving patients downstream the kinds of incentives. Policy solutions, I think you're also going to need to see getting the incentive rights, Medicare or public option-led innovation. There is increasing evidence that most innovation actually comes from Medicare. So if you look at the share of pricing by private insurers that deviates from Medicare, it's very low. So really, and where did ACOs come from? Now we can debate whether or not they're effective, but contrary to a lot of other industries, much of the innovation that we have seen has come out of the public sector. That only will likely continue to happen. Also facilitating organizational innovation or entry. So related to Kaiser, related to Intermountain, I think there is a role from a policy perspective of facilitating more vertically integrated innovators. If you look at kind of I bundled these three together in the middle, but I do think there's a role for these kinds of AI-based decision support and effective market design. That's going to be particularly important for overcoming and getting the most out of these market-based solutions. On a regulatory side, I think you would also hope for limited product differentiation, maybe even smart defaults. So in Medicare, for example, low-income enrollees are actually randomized. And who picks up the bill if their drug isn't covered? We do as taxpayers. A smart default would say, if you're on this medication, I'm going to default you to that plan. You can opt out if you really hate Aetna or have some strong brand preference. That smart default alone in Medicare Part D, which we have the data and the technology to do, would save us $4 billion a year. So I think smart defaults, or even think about it in states, could be very, very effective, and also restricting or limiting choice sets. If we don't see a lot of innovation, we're not losing much by saying to insurers, you can't have an unfettered benefit design. You need to compete within the rubric that we have put out as a market designer. And lastly, on private sector innovation, I think data and quality measurement is a central issue. And I mentioned briefly the all-payer claims data that was in Utah. Many states are building these. California's doing one now. Massachusetts has one. I think about 12 states have them out now. They're incredibly valuable for getting a comprehensive picture of the state of healthcare in a state, but they also allow you to measure this kind of innovation. rather than relying on, say, well, if someone buys it, it must be good, you can actually look at which insurers are effective at managing cost, which insurers are effective at managing chronic disease. And that could be done on the private sector side or from public policy perspective, but there's certainly a role for data availability that's going to come from the regulator. And also risk adjustment. I've not talked about it too much, but that was central and has continued in the early days of the successes of Obamacare exchanges, has been the role of, well, the 3 R's: risk adjustment, reinsurance, and risk corridors. And so that's also a central policy option. So with that, I will conclude pretty quickly and take questions or discussion. So just to recap some of this, I think U.S. healthcare costs, right, it's linked to broader issues, income and social structure, not simply the healthcare system. Efficiency here is not just lowering cost. It's reducing low-value care and increasing high-value care. We don't have great evidence that the private plans today are delivering this kind of efficient cost reduction. And I think that suggests a very important role for policy in facilitating innovation. That can come in a lot of different flavors, but it seems like that's going to be critical going forward, both because people are not effective, the demand signals are not very effective, and entry has been very limited in this domain. So thanks for your time. I look forward to questions.
Ken Yonda, a recovering insurance executive, so know the perspective. One of the things that was on your slide, but you didn't really talk about, was risk adjustment, because this seems to be a pretty significant innovation in the private market, both in the Medicare Advantage as well as now in the marketplace. But it seems to me that most of the insurance innovation around that is how to maximize getting a higher payment rate rather than actually managing the cost of diabetes. Is there any evidence or studies that have gone to show the potential inflationary impact of risk adjustment?
So that's a great question. I think you're absolutely correct to say that you have what we as economists call second best, but basically saying you have trade-offs when you do these kinds of things. And Medicare Advantage is the place where we've seen the most of it. And actually, this is Mike over here, who's an absolute expert in this. And you really have two competing forces when there's kind of these information problems, is that if I'm more effective about risk adjustment, on the one hand, it makes you more willing to take someone, say with diabetes, we'll use diabetes as the example, and it increasingly rewards lowering cost. So I'm getting a fixed risk-adjusted payment. If I lower the cost relative to that, it's more profitable. And in fact, I've taken them without bankrupting the plan because of risk adjustment. So that's sort of the good news. The bad news, particularly in Medicare Advantage, is making people look sicker is also rewarded. And you know, what's easier than lowering cost? They weren't costly in the first place. We just looked sick. And I think that's a critical trade-off that's important to manage in these domains regulatorily. And you know, frankly, I think there's been pretty blunt approaches from CMS that have not been very effective in mitigating upcoding and these kinds of things. But I would also argue, and you know, I think there's basically, there's two strands of literature. One says Medicare Advantage is much more effective at managing these kinds of diseases. I mean, I think a fascinating one is if you look within the same insurer, so Aetna will have a Part D plan where they don't have to pay if you go to the hospital, and Aetna will have a Medicare Advantage plan where they have to pay if you go to the hospital. Turns out their formularies are actually quite different. They cover more management and maintenance drugs when they have to pay if you go to the hospital. So that's sort of the good news side of this. And then you have work basically showing people look a lot sicker when they show up in MA in ways that are not explained by the acuity, and that's the cost of it. So I think that's something that would have to be dealt with. This gets a little bit to the role that a market designer or effective regulator could play in getting competition that we might like. And I will use I can use California as an example. Peter Lee, who ran the exchange, and if you look at who went to Sacramento in the early days of the Cover California, it was people leaving McKinsey, it was people leaving top places. They took the best and the brightest in there. I think have been very effective at running they asked for 5-year contracts. They were really smart about design. Doesn't mean there's not funny business, but I think that's what if you have that, then the private sector, if you do a good job, you really can get market share. HealthNet has expanded a lot and gotten really good market share there. But you have to have that kind of regulatory apparatus. I don't know if that's getting a little bit to your question, but I think there's no free lunch. There's no silver bullet here, but that would be a better trade-off in my view than just kind of care or plans that are not really covering people and are mostly selecting for just lower cost people on average.
I wanted to know, because of recent vertical integration within the healthcare system, i.e. Aetna, CVS, HealthScript, have you seen any issues with that one? Because there is a lot of economic power centralized at those places. And have you studied that, and what have you come up with?
I haven't studied it, so I haven't come up with anything. I mean, but I'll speak to it a little bit. And there's certainly experts here, apparently not me. Dr. Scott Martin is sort of really an expert on antitrust and these kinds of questions. Because I think, so that comes up there insofar as there's increasing concentration both horizontally and vertically. And that relates to the PBM space. So I mean, if you looked at kind of why are they doing this, I am skeptical it's because they want to have really great clinics in the CVS. I think it's because basically there's 2, maybe 3 PBMs, and they want to control that. But that said, I do think related to that and also to Walmart's, frankly, fantastic healthcare group that's really innovative, I think, anyway, we'll see what they come up with. Amazon's possibly overhyped, but potentially doing something, healthcare group. I think you would, this idea that there's going to be more consumer-directed and retail kinds of things that are coming from outside of insurance is potentially an exciting form of innovation that may look a bit more like my optimistic view that you can manage diabetes where people are much better if you have access to lower cost, high value kind of clinics in a Walmart, that kind of thing. The concern would come in a world in which data is still very fragmented and you don't have these relationships, how effective they are at getting people the more acute kinds of care and the kinds of care that go further up the cost distribution and the intensity distribution. So someone who has Walmart and a teaching hospital does not have the same care as someone who's fully in Kaiser Permanente, for example, or fully in Intermountain. And I don't think we should kid ourselves that just because we have those two things, we're kind of getting this new form of healthcare. That said, I think competition in the structure that we have that comes from outside of the insurance industry is probably good in that domain.
Elena Marks, Episcopal Health Foundation, and I live in the health, not just healthcare world, and so I'm curious about your slide on infant mortality rates and how the increase was with time. And you had a few slides on health outcomes, but mostly you're talking about the cost of healthcare and how do you bridge those two and what is there that we could be doing to improve those health outcomes that none of this really gets at?
Yeah, so I think it's a great question, and I'm doing it for a couple of reasons. One is I was ordered to do it because we're talking about healthcare costs. But no, the other reason, frankly, you'll notice that all of these studies are looking at things that I say we know are good or bad for healthcare, or sorry, for health. One reason to look at statins is we have good medical evidence that taking your statins is good for you, and we can sort of say that's a good thing. Partly we have to do that because we don't have very good data. And I think, and in Utah, we're now working on it because at least for some populations, we have 10, 20 years of data, and so you can follow people much longer. I think back to kind of what could be done that really combines public and private sector to efficiently reduce cost, these all-payer kinds of data sets and even more comprehensive data environments are going to be absolutely central to that. So if you go, for example, to Scandinavia, you can follow people over time and figure out whether this treatment was effective, not just because on average in one clinical trial it was effective, but because in the wild, when it's prescribed to people, it is effective. In fact, in Denmark, they always do a clinical trial internally, but they can replicate it in the population because they have a data environment to do that. And I think that's going to be really important to getting the kinds of, whether we have something that looks like what we have today, whether we have Medicare for all, whether we have something in between, having the ability to measure this more comprehensively is going to be absolutely central to moving in that direction, because ultimately I'm just using surrogates because that's all I have, and we need to kind of act on it. But taking statins is not desirable in and of itself. It's desirable only if, in fact, it's mitigating the clinical outcomes. So that's a little bit punting, but I think I am cautiously optimistic that we're increasingly able to measure these things both from the kinds of clinical side electronic data and also these more comprehensive data sets. I would also add that one thing we're doing in California, they've done it in some other states, is increasingly linking across domains as well. And this gets back to a little bit of the beginning, which is we could have a much better view both of the value of health insurance and the value of education and the value of other social programs if we put them together, right? These things in isolation, for example, and this is in Denmark, if you look at basically giving people more intensive breast cancer treatment, you can show that it improves health. It dramatically lowers disability payments, increases employment, increases tax revenue. And so the return to this expensive radiotherapy, this was a long time, when radiotherapy was there, was actually much higher if you were able to link across domains. And so I think just viewing health in the broader context of the human is also going to be very important from a public policy perspective and also in this kind of ROI value type of question.
Good morning.
Hi.
First of all, my name is George Perkins, and I'm with the University of Texas MD Anderson Cancer Center. And we are honored to partner with the Baker Institute precisely for the programming, among other things, as well as speakers like you who come and provoke thought. Having said that, I want to mention something that I would consider to be the elephant or the rhinoceros, which is when we talk about plan design as well as what people do or don't do, what we're really talking about is choice and freedom of choice. I would suspect that some of the differences you would see in Texas and California, as a native Georgian, this state has a very large emphasis on freedom of choice and the ability to be independent. Having said that, my question, when you look at the chart that you placed up, especially all the things that look at AI and plan design that really look at rational thought, and when you look at the people who perform best in that system, statisticians, physicians, those who are capable of consistently doing rational thought, what innovations do you see coming forward for the majority of the population that does not necessarily perform rational thought while trying to maintain freedom of choice and not wanting choice removed from them, yep, and often making choices under emotional circumstances where it's very difficult to separate and act on rational thought?
Yeah. No, and I think that's a very critical issue or question here, and I it's whichever large pachyderm is in the room, it's certainly relevant here. But I think you're absolutely right, and the interesting thing, and there's a bunch of studies on this, of people who make a choice are satisfied with the choice, regardless, arguably, of how many choices they had. So I think one rationale would just be to say, we can do a lot better in limiting choice and still give a lot of choice here, right? That domain is potentially a great opportunity. We don't need 45 Medicare Part D options. We could have 5. People can still, have all the freedom they want. We're just mitigating some of the very bad choices they could make. So we refer to that as a choice set danger. There's a kind of a fascinating paper, which is a bit of an aside. They look at chess matches and show that basically if by changing the danger of your move, you can turn a mediocre player into a world-class player. That most of the quality of chess is actually how many mistakes you could make, not the quality of you as a player, which I think is very relevant here. So you don't need to go to zero. And so I think that's very important. The other is that in health and in health insurance, there's an externality of the choice. So, putting my economist hat on, I'm happy to give people all the choice they want, and in fact, I'm happy to let them make mistakes that are only costly to them. Now, if in fact it's costly to us as taxpayers, it's costly to us in terms of total healthcare cost, it's costly to us in terms of communicable diseases, then there's a different rationale for saying, okay, we like choice, but there's a rationale for some kind of intervention in the externality sense, and I think you'd also have that here. And I think the one exciting thing about the AI is it's just a tool. So what we see is that, in fact, all you're doing is scoring plans. And I think that's pretty exciting because we see that people really follow it and are satisfied with it, but they still have 45 options. And some people do overturn it. And so you can have that looking a little bit like the kind of nudge literature, which is saying, they call it libertarian paternalism, which is I give you lots of choice, but I'm just going to move you in the right direction. And lastly, I would say, that Medicare Part D example I gave is a great one, which is costly to all of us as taxpayers, to the tune of, $5 billion a year, the fact that people are just randomized. You could default people saying, you're on these medications now, this plan covers them. You can choose anything you want, but this is, if you don't do anything, we're going to put you there. And in fact, I think Mike's going to talk about this in Medicaid, and I think that there are very effective ways to do this. And in fact, in some ways, technology and AI can make us much more effective at doing that. Because without it, you're saying, well, I don't really have a good way of figuring out your preferences or what kind of a rational person would do. So I either give you one option, which is not a lot of choice, or I give you tons and people are just in the Wild West. So I think it's a complement to exactly what you're saying here, is that you can have this kind of libertarian paternalism that could be very effective across the political spectrum. All right, thank you.
Thanks, John. That was absolutely terrific.